Good morning. My name is Nicholas Gaudet. I'm one of the residents in Toronto, and I want to present this. I have no disclosures to report. As everyone in the room is surely well aware, Conn syndrome is a aldosterone-producing adenoma, and it typically presents with the classical clinical picture of hypertension and hypokalemia, although this is certainly not always the case. In working up patients with this presentation, a differential diagnosis is fairly extensive and must be worked up in order to prevent misdiagnosis. A well-established three-pronged approach to workup prior to surgery involves three phases: screening, confirmatory testing, as well as a subtype classification and localization of a tumor. Screening typically is performed measuring a plasma aldosterone to renin activity level. The confirmatory test is a saline suppression in order to suppress endogenous aldosterone. And sort of the most relevant to the surgeons is the CT scan localization, as well as lateralizing confirmation with adrenal vein sampling. My interest was to see how well we have been adhering to some of the guidelines in Toronto, and our chart review encompassed a 2003 to 2012 series. It was 146 patients who underwent laparoscopic adrenalectomy. Of those, 31 were for primary hyperaldosteronism. The study variables included were the biochemical assessments, the surgical indication, the radiologic assessment, and some of the complications. The results I'd like to highlight are these. Basically, the proportion of people who received each of these standard workup. You can see the screening is certainly almost everyone has that recorded, and the reliance on cross-sectional imaging seems to be highlighted as well, although selective venous sampling is performed in only about half of patients. We had one complication I would like to highlight, which is the persistent hypertension post-surgery. This was initially managed with a spironolactone, and eventually patients underwent reoperation for this. Some of the pitfalls with localization using CT versus vein sampling have encouraged more liberal use of vein sampling. Some of the estimates out of a group in the Netherlands indicated 3.9% of patients may have had surgery on the wrong side, versus comparing vein sampling to CT, estimated that a CT would have been normal in about 19% of patients who actually had a positive vein sampling. Therefore, the important reason to adhere to the third phase of our workup certainly would be to reduce the rate of missed or inappropriate surgery, as well as to differentiate more adequately between bilateral hyperplasia and a aldosterone-producing adenoma. Therefore, my conclusions that currently in Toronto, the trend has been to rely slightly too heavily upon cross-sectional imaging and or screening. This certainly should be encouraged to strive for more adequate vein sampling. Thank you.
Questions from the audience? I do have one question. So if you have someone who has a diagnosed aldosteronoma, CT scan shows a clear unilateral mass, do you still routinely do vein sampling on all of those people?
I think despite there being a lesion on one side that could represent a non-secreting adenoma, in fact, the underlying diagnosis could be bilateral hyperplasia, which potentially could have been what happened with our patient, in that the visible lesion was resected, but the disease actually was bilateral and would have responded more appropriately to medical management.
And what's the sensitivity of the the vein sampling? It's not 100% accurate?
It's not 100%, but I think it's superior to CT scanning alone, for sure.
Other questions from the audience? I believe we had a no-hitter here on web questions and on text questions. So that's the end of the session. I want to thank all of the speakers for a really nice job with their presentations, for staying on time, and appreciate all of you coming here early in the morning. And hope you got to know your neighbors even though they're a little far away from you. Thank you very much.